you can see how these papillas have filled in, and it only takes around 6 months or so for that to happen. And there's again, not rocket science, just follow the guidelines and you'll know what you can expect. Now, let's spend a moment again on biologic width, because biologic width also affects papillas. And I don't know about you guys, but biologic width is something that I struggled with as a clinician a little bit. When I was in dental school in the early 70s, I remember sitting down to do my very first anterior crown. I was a junior. They didn't trust you to do that until you were a junior. And I sat down with a board-certified crown and bridge prosthodontist, and she said, "Okay, Mike, let's put that crown margin right on the bone to make sure that we don't, show any of the restoration." Well, we didn't know any better at that time, although if you look, this was published in '61, and I'm talking about '74, but it hadn't translated into clinical practice. And then later, as we all began to learn about biologic width, that we need, some space for the attachment apparatus to attach, about 1 millimeter connective tissue, millimeter of epithelium in your sulcus, and that if we use bone as our constant and we measure from the bone and you place your margin 2.5 millimeters, that you're never going to infringe on the biologic width. Well, I can tell you as a clinician that didn't make sense to me. I can tell you that I oftentimes would see crowns that I knew that the margin was right on the bone, yet there was no inflammation. I also would see crowns that I knew were at least 2.5 millimeters from the bone. And I went through a differential diagnosis, and I knew there were no other reasons for this inflammation, yet they were chronically inflamed. It just didn't make sense to me. It started to make better sense as I looked at Vasic's article here, where he basically just repeated Gargiulo's article, his study. And what did he find? He found about the same thing, about 1 millimeter connective tissue, millimeter of epithelium. But what you look at is the range here. The range on epithelium, 0.3 to 3. Connective tissue, 0.3 to almost 2. So, it's this patient right here that has that crown on the bone that didn't cause a problem, because this patient has a 0.6 millimeter biologic width. I'll take a practice full of those folks, because it's this one that reaches out and gets you, that has a 5 millimeter biologic width. This is the patient that you place your crown margin 2.5 millimeters from the bone because you're doing what you think you're supposed to be doing, and you're in the middle of the connective tissue attachment on this patient. So the bottom line is a biologic width is a constant, but it can vary greatly between patients. And in our practice, we calculate the patient's individual biologic width. After they're anesthetized, I'm going to sound from the free gingival margin to the bone, subtract the sulcus depth. That's going to give us our individual biologic width. That's important in papillas because variations in the biologic width also affect papillary height. Again, if we have our typical 5 millimeter papilla, on average, it's about a 3 millimeter sulcus depth, about a 2 millimeter biologic width. Well, you can have variations. You might have a 7 millimeter papilla here. If you have a 5 millimeter sulcus depth and a 2 millimeter biologic width, this may not be a very stable situation. Yet you can have that same 7 millimeter papilla, but if it has a 4 millimeter biologic width, it's going to be much more stable. Periodontal biotype also influences papillary form, obviously. You can have your highly scalloped or your thick and flat. Some suggest that the thick and flat's more stable, but as far as papillas, that's not really perhaps the most aesthetic, so that's a problem. Other papers have talked about how we can go in and rebuild these papillas surgically. And unless I've missed somebody, I believe this is the world's literature on surgical rebuilding of papillas. And I've learned much from these master clinicians. But all of these papers have one thing in common. All of them are single case reports or small case series that tell us nothing about predictability or long-term stability. Now, can you rebuild papilla surgically? Sure you can. Patient of mine, open interproximal space. If you need a papilla, why don't you take a papilla? So, I'm smart, I'm going to take this little papilla from the lingual aspect between these bicuspids, there it is. Let's create a little pouch here, place a papilla there. Is this my before picture? No, this is my before picture. If anything, he looks worse after that augmentation than he did before. I didn't grow it where I wanted it, but boy, I grew a nice wart of tissue right out there, though. So, you know, let's make lemonade out of lemons and let's move this tissue here. But could I do this if these teeth were not prepared? No. So I'll take that in the form of a pedicle graft, I'll move it in proximally, and we create a nice papillary form. How about this patient? This is another dental hygienist. She went to somebody and they did connective tissue grafts that they all failed. Hard to believe in today's world that, you know, connective tissue grafts are so predictable, but not only did she lose all this tissue, but more devastating to her, she lost all of the interproximal papillas here. So we're going to go in, we do connective tissue grafts first, and we achieve exactly what we thought we would achieve, and that is we're going to graft just down to the height of the contour of the interproximal tissue. But that's not enough. Now she wants us to see what else we can do. So we're talking about procedures here that have high value to the patient, but also high risk. The more you get into this kind of stuff, if this fails, you only thought she looked bad. So we're going to go in, we make a full thickness incision in the vestibule, basically deglove the maxilla around these teeth. We're going to move it down. We're going to undermine all the way to the lingual. I place a little bone and a little piece of connective tissue over the bone. We'll suture it, and after restoration, we get a reasonable result. But again, these patients are willing to go through these procedures because it's so important to them that they recapture the papilla. How about this patient? This patient was sent to a periodontist to have a regenerative procedure between these central incisors, and it was done with a membrane, and frankly did a pretty good job of regenerating the bone, but lost the papilla in the process. Now, high smile line, what would you do if this were you? I know if it were me, I would do anything to recapture this papilla. So the first thing I do is I go in, I'm not trying to put anything in the interproximal region, I'm just bulking this tissue out to give me something to work with. So here is our graft in place, and here we have it 30 days, so we've got some tissue that we can work with here. I actually recontour these teeth to give me a little more space interproximally. I place a little interpositional graft, a little connective tissue from the tuberosity. I'm going to coronally advance then in the form of a pedicle graft over that, and this is at the end of that surgery. And this is how the patient comes the next week. Now, this is a very important little window of opportunity. You can see that we've grown a little tissue here, but if I send this patient home, that's going to round off. We're going to lose it because remember, contact point and gingival embrasures help maintain this. So that day, I have to add a little flowable composite to make sure that I have my provisionals lightly touching that. And if I do that, this is what it looks like at 30 days. You know, I'm having, as a periodontist, to relearn some restorative things. I mean, I talk about flowable composite, what's that? So is it possible? Yeah. You know, we were able to regenerate a tremendous amount of tissue here, and with that high smile line, very important. And I have, you know, detailed surgical slides on all of these and others, and I could write this up. But you know what? I don't know I could do that again, much less show you how to do that again. But we have to address something to be able to do this more predictably because this is such a high-value procedure. And I believe biosurgery will allow us to do that in the future. Biosurgery is surgery with an active component. I'm convinced that in the future, you and I will not be doing any surgeries that are passive. Everything will have an active component that will allow us to be less invasive and allow us to achieve things that we can't today. What if I, on demand, could increase the width of the biologic width? I mean, increase the amount of biologic width. I could grow papillas without changing bone level. Well, I'll end my presentation by giving you a brief overview of a study that we published in Journal of Periodontology this year in '07, and this is the first randomized controlled clinical trial ever done on augmentation of the papilla, and we used a novel approach using the patient's own fibroblasts. The fibroblasts are extracted from a little biopsy. They are sent to a laboratory. In the laboratory, these fibroblasts, a cell line is made. They're grown out to about 200 million cells per ml. They're placed in an injectable medium, and we then take them to the papilla and we inject the fibroblasts into the papilla, expanding the papilla. Now, we're not injecting a collagen, we're not injecting a filler, we're injecting living cells. Think of it as a dynamic protein delivery device that's not only going to maintain that over time, but perhaps continue to help plump it out. Now, we know a little bit about the structure and the vascularity of the papilla, but we're just really now learning a lot about gingival fibroblasts. I mean, I used to think of them as very boring cells that around produce collagen, and that's about it. But if you look at the cytokine expression from gingival fibroblasts, they produce all sorts of things, and some of them that they produce we've already identified as being important in regeneration in periodontology. They're important for cell proliferation, extracellular matrix production, growth factor production, cytokine production. And they have a great deal of phenotypic heterogeneity. In other words, you can get more undifferentiated mesenchymal cells from gingival tissue than you can any other tissue in the body. And if you can take those cells and direct them in the right way, theoretically, you could actually get regeneration from these fibroblasts. So in our study, we had 20 patients, total 118 sites. 40 of those were matched, randomized, and test control. Primary endpoint was a change in the baseline from the papilla to the contact point. And we measured it with a probe, with a caliper, and with digital analysis of our photographs. We also had secondary endpoints where we looked from the base of the contact to the alveolar crest, and we looked radiographically at the bone. So here at baseline, we're going to take our biopsy, we'll send it in, and have a cell line made before the cell line is sent, or before it's sent back to us. These cells can be immortalized, and so that you can come back and use them again without taking another biopsy. And this is how it looks when it comes to our office. Again, you're not looking at collagen, you're looking at living cells here, but I would imagine everybody in the audience has injected anesthetic into papillas, and you know you can't get any in there, right? The tissue is too firmly bound down. What makes us think that we're going to be able to expand the papilla with this kind of technique? So we developed what we call the papilla priming procedure. It's just a controlled surgical insult that allows us to go in and cause swelling. It also gives us access to all of the components of the papilla, to the bone, to the periosteum, to the connective tissue. And so if you look and see what happens, here is the papilla priming. At 3 days, you see it's swollen. At 7 days, it's beginning to mature, but it's still swollen. And at 21 days is all back to where it was. Well, let's think about what's going on a cellular level, because we use this concept as our experimental design. If you think about their wound repair, everybody agrees there's 3 phases of wound repair: inflammation, granulation tissue, and matrix formation and remodeling. And when you look at this, it looks very fixed and unyielding. But in nature, these different areas, inflammation and granulation tissue, they can last longer. Some domes don't last as long, and there could be considerable overlap. So let's think what happens as we go through this. When we start our papilla priming procedure, within seconds, plasma proteins, primarily fibrinogen, coat the wound surface and begin the process of wound repair. Within an hour, we enter the early component of the inflammatory phase, and neutrophils begin to come into this area, and within 12 hours, we see swelling above baseline as the body begins to upregulate the production of fibroblasts, because the body's trying to heal itself, so it's regulating its own fibroblasts. These fibroblasts are producing collagen. By 3 days, we enter the late component of the inflammatory phase. The neutrophils are replaced by macrophages. You see that you still have swelling, but it's looking more mature. These macrophages are producing growth factors that are supporting angiogenesis, fibroblast production, and collagen accumulation. And as we move into around 5 days, we enter the granulation tissue formation phase. And at around 5 to 7 days, the body begins to shut down the natural production of fibroblasts. And collagen accumulation then begins to diminish, and you start getting into wound contraction. Most people agree that it's the length of the granulation tissue formation phase that'll dictate how much tissue you have at the end of a wound. For example, if you have a very short granulation tissue formation phase, there's not a long enough time to produce fibroblasts, collagen, and all those other things to create tissue, so you could end up with a net loss. Theoretically, if we could increase the length of the granulation tissue formation phase, though, we could end up having a net gain, and that's what we tried to do in our study. So here we're coming in, we're injecting fibroblasts into the papilla. You can see as I do this how the papilla begins to blanch, But also look when we're doing our injection. We're doing our injection about 5 to 7 days after the papilla priming. Why is that? Well, it's because the body's shutting down its own production of fibroblasts at that point, so we want to go in and jump-start it again, hit it with some more fibroblasts. And you can see it blanching here. We're able, on average, to inject somewhere between 6 to 8 million fibroblasts, and we dose that 3 different times at 7-day intervals, trying to get the most of the fibroblasts as we can into that area. This was taken off of one of the dermatologic papers using this material, and you can see that at 6 months you have more fibroblasts, more a thicker dermis, no signs of inflammation. What happens is after the fibroblasts are injected, they take their spot in the normal dermal architecture, begin to produce collagen, and stimulate native cells to do the same thing. So that's our experimental concept, that we went in and strategically injected fibroblasts to keep this granulation tissue formation phase going in an effort to rebuild the papilla. Now, what we found in our conclusion, we had our patients were blinded to the placebo and the cells, and we had a blinded examiner, and we found that both with the blinded examiner and the patient that we found statistically significant improvement over the papilla in papilla height. In other words, our patients thought this was working, and our blinded investigator thought this was working. And since this is a procedure that we do because of patient desire, that is a very important finding. But the problem that we had was that our objective measurements didn't correlate with our visual analog scale. One reason that could have been is because we weren't measuring volume of tissue, we were only measuring height. And one of the things that perhaps the patient and the blinded examiner were seeing that they found more pleasing was the fact that we have plumper papilla, as you can see here, and we weren't capturing that. So that may be one of the reasons. But certainly our measurement techniques were problematic from the very beginning. You're dealing with papillas that are spaces that are, you know, in the 2 and 3 millimeter range, and if you're using a standard perio probe with a standard of error of about 1 millimeter, you would get a 50% improvement or decline in result and not even be able to measure it. When we were using our digital caliper off of our models, by virtue that you have open interproximal spaces, when you take that impression out, it's going to tear. That introduces variables. Our best and most sensitive was using digital analysis from our photographs. We standardized all of our photographs as far as magnification, but they weren't all standardized as far as angulation, and they went in mathematically and corrected that on the XYZ axis, but still there's some error. We also found that papillas don't always look like we were taught they would look like. You know, we're taught papillas look like this, right? Lots of papillas look like this. Many papillas are concave, not convex. None of these have been treated. You know, so the way that we think papillas, you know, the way we typically think they don't always look like that. In fact, most don't. I'll share with you just a couple of the patients as far as the results here. On all of these panels, this will be day 0, 4 months, papilla priming, first injection, second injection, third injection, 2 months after and 3 and 4 months after the first injection. And it's easier to look here on, if you look at the timeline here. This is papilla priming, first injection, second injection. Look how much growth we have in the papilla from the second injection to the third. You know, no more cells are put in there, but these fibroblasts are sitting there generating the connective tissue, and it's closing the papilla. Then this is third injection, 2 months, 3 months, 4 months, maintaining pretty much out. Another patient, papilla priming, first injection, second injection, third injection. Okay, no more injections are given, but look how the papilla closes down, how the open interproximal space closes down as the papilla grows. Again, the fibroblasts are producing the collagen, closing the papilla, even though no more injections have been given. Another case, papilla priming, first injection, second injection, third injection, again, completely closes, then we get a little rebound. So our conclusions from this study were autologous fibroblasts are safe and may be efficacious for treatment of open interproximal spaces. Investigator and subjects to VAS assessment of test sites were superior to placebo, but our objective endpoints failed to demonstrate statistical significance. Further studies are needed with more appropriate power and sensitive measurement techniques. We are now doing a study with more sensitive measurement techniques, allowing us to have very standardized photographs controlling for all the angulations, and we're looking also at dosing in this, at what time should we be dosing. One of the things we found in the first study was that on the whole, people did very well up to about 2 months. And then we started getting some variability, so we're looking at dosing schedule as well. And if things go well, we hope that one day we'll be able to get into a multi-center trial and be able to, now that we know it's possible, find out how we can make it more predictable. An interesting article at least caught my eye in this year's Journal of Periodontology. A group out of Canada showed that fibroblasts from papilla act different than fibroblasts from the just gingival marginal tissue. And as I read that, it made sense to me as a clinician, because if you have a patient that's on immunosuppressive drugs, or you have a patient on Dilantin, where do you see the growth first? It's always in the papilla, isn't it? So I'm thinking that if we do further studies, we don't want to take our biopsies from the palate like I did. Let's take our biopsy from a papilla itself, someplace outside the aesthetic zone. But of course, we know from the guidelines I just told you, if you've got the bone, the papilla is going to grow back, right? So we're not doing anything wrong. That may also be a real key as we move into this area. I'm going to end by wanting you to focus in on this panel. Again, in today's world of computers, you can do anything you want with computers, but this is not computer altered. You're just going to look at a time lapse from day 0 to 4 months, and so focus here. Now that we know that it's possible, if we can make it predictable, I'll be opening papilla parlors next to every bright smile across the United States. Certainly, our grafting instruments in the future may be very different than our grafting instruments in the past. It is about the smile, and I'll leave you with one of my favorite quotes. A smile costs nothing but gives so much. It enriches those who receive without making poorer those who give. It takes but a moment, but the memory of it sometimes lasts forever. None is so rich or mighty that he cannot get along without it, and none is so poor that he cannot be made rich by it. A smile creates happiness in the home, fosters goodwill in business, and is the countersign of friendship. It brings rest to the weary, cheer to the discouraged, sunshine to the sad, and is nature's best antidote for trouble. Yet it cannot be bought, begged, borrowed, or stolen, for it's something that has no value to anyone until it's given away. Some people are too tired to give you a smile. Give them one of yours, as none needs a smile so much as he who has no more to give. It is revolutionary what we can do today, and it will be even more so in the future. All of these kind of procedures, especially as we move into biosurgery, surgery with active components, should provide for all of us an increased scope of practice, but more importantly, provide for our patients treatment that's less invasive and more predictable. Thank you very much.